welcome to this Emergency Care Improvement Support Team podcast. Today we're going to be chatting about some of the challenges that have been faced by the junior doctor workforce, particularly through the pandemic. And I'm joined today on the virtual sofa by my colleague, Dr. Dan Smith. Dan, I'll let you introduce yourself, if that's okay.
Yeah, thank you, Claire. Yeah, so I'm Dan Smith. I'm a respiratory doctor by trade. I'm a final year registrar in Nottingham University Hospitals, but this year I'm non-clinical actually, which is quite an interesting choice in the middle of a respiratory pandemic. But I work 4 days a week for NHS England in the Midlands, and I work 1 day a week for the Emergency Care Improvement Support Team with you, Claire, and I've been doing that role for the last 3 to 4 years now.
Yeah, great. So it's probably been quite a useful time to be sort of non-clinical, really. You can really see what's going on from the outside. I know we see that a lot with ECIST, and I know we've already started to chat about some of the things we're going to sort of touch on today, because you're really passionate about this, and I think that's sort of come to light over the last sort of 12 months for you, hasn't it?
Well, I'm passionate about kind of junior doctor lifestyle and well-being and work, because I've been a junior doctor now. This is my 11th year as a junior doctor. I'm an old man for a junior doctor. And even the language that we use to describe juniors as juniors is quite a challenging language. Politically, it's quite challenging because you got to think an awful lot of our junior doctors have been doctors for 10, 15 years or so.
Yeah.
So it's an interesting term that we use to describe such a large proportion of our medical workforce.
Yeah, because you do associate junior with juniors, don't you? And babies. That's they're quite young. So
yeah, and I'm very much coming towards the end of my junior doctor life, but I still describe myself as a junior doctor just to keep myself as part of the same cohort as the very junior doctors. But I do think it's something that we do potentially need to look at in the future of relabeling us all. I don't think it accurately describes the amount of training and experience that all doctors have, really.
No, it doesn't. So I'm a nurse by background, Dan. I don't know if you know that, and so I've worked closely with doctors over the 28 years that I've been in the NHS, and just that point of the fact that you're in your 11th year, that's from a nurse's point of view, I wouldn't be classed as a junior at at 11 years. So what are some of the challenges that you find with regards sort of the training around the junior doctors and things?
So in terms of, I'll talk about the challenges that we've had in the recent time due to COVID, and maybe we can expand on that into kind of just normal challenges. But you got to think that I'm not definitely saying that junior doctors are special. I'm obviously special, but I'm not saying that all junior doctors are obviously special compared to other members of the workforce, because everybody has had such unbelievable challenges. And I'm not just talking about clinical frontline staff. This is everybody has worked in a completely different way over the last couple of years. However, there are some things which are particular to junior doctors which have impacted on them. We're one of the only workforce really that on a yearly basis we're expected to transition or progress to the next year of our training. And as you say, as maybe in the nursing workforce, that's not really as specific. Obviously, everybody has progression in pay points, but also in their training. But it's not something that you have to go through on a yearly basis, whereas as a doctor, we have to progress yearly. And so therefore, any interruption into the availability or the accessibility of training, it really puts a stop to that. And also that can therefore be really quite worrying for doctors who depend on the next year of their training for their next bit of progression, and also for their appointment to new posts. So, for example, almost all of the junior doctor interviews last year were understandably cancelled face-to-face because people couldn't safely do them. And so people therefore had to revert to scoring people's application forms just on the basis of their application rather than on the face-to-face element. So there's been lots of disruption, not just to your training, but your progression as a doctor as well. I don't think anyone expects as a doctor to go through what we've all been through in the last year and have no impact on our training. I think that would be unrealistic. But we are talking that there are junior doctors out there who might have years added to their training program because of the lack of opportunity that they've been able to access. Really clear example for that. This has impacted me a little bit as a respiratory doctor, but definitely impacts more kind of the surgical specialties, is when you do endoscopy now, because of infection prevention and control procedures, you can't see as many patients as you would do beforehand because it takes longer to clean in between. So that means that maybe 50% of your training has disappeared per week. Obviously, going to see a patient in clinic offers us all an educational opportunity, especially because we work alongside experienced consultants. But now we're doing phone call clinics with patients. It's not as easy maybe to access those educational opportunities. So you can see, yeah, definitely I could be described as passionate about this. I think Health Education England and even GMC have done a lot to try and support junior doctors in this period, but it's going to take 3, 5, maybe even 10 years to see some of the outputs of this, the consequences of how this has impacted the workforce.
Yeah, I mean, I was just going to ask what, that's quite worrying for a lot of you, isn't it? I mean, as you say, it's, you've committed a lot of your lifetime to your training and your development. So what support is out there for you to access?
Yeah, so directly every trainee has supervisors, and we have both what we call a clinical, which is the more kind of operational, how you do your day-to-day job, but then we have an educational supervisor as well. And the educational supervisor, their remit is to look after you more kind of holistically, both for your well-being and your longer career plans. And they have a little bit of flexibility about what they're able to suggest or offer you. Maybe they say, okay, this particular course would help to kind of catch up a little bit, but they are not able to rewind time and find 6 months more training for you. So those things are difficult. We have training program directors that work on a regional basis to guide our training, and they're the people who decide which hospital per year you're working in to make sure you fulfill your competencies and pick up your curriculum competencies. But again, there's only so much they can do. If this NHS structure and the pathways we deliver care to our patients has fundamentally changed, then our training has fundamentally changed. And it's to say it's going to take a couple of years for those things to completely work our way through. The consequences of this in the immediate time are there are junior doctors at the beginning of their careers who are really questioning if they want to carry on in the same career choice that they initially had. There are a lot of doctors who maybe would have ended up as hospital doctors and now choosing to choose other routes. Those other routes aren't always easier, things like primary care, but they're choosing other routes. But then there are doctors in that middle period before we become a registrar, who are really struggling to get onto those training programs because, as I said earlier, the interviews of things have been cancelled. And then right at the end of the pathway where I'm getting towards, there are people who are going to have a year, 6 months, 18 months, 2 years added to their training program. And that creates a bottleneck, because if you can't take someone out at the end of the pathway, you can't accept another one into the beginning of it, because we've only got a finite amount of funding. So lots of challenges. There's lots of help out there. I don't think we've got yet a systematic across the nation approach to how we're going to make these improvements there. I think at the moment it's depending an awful lot on individuals to try and support each other.
Yeah, it sounds like a logistical nightmare, really, doesn't it? And, from a rotoring point of view and things like that, it must be really challenging to be getting the hours in and the, as you said, the clinical practice in that you need. Yeah. So how have your colleagues been finding that over the last sort of 12 months?
So I wouldn't say there are many medical colleagues who haven't had a change to their working pattern over the last 12 months. And for some of our doctors, it's happened 2 or 3 times when we've gone through the different waves that their working pattern in very short notice has been changed. Obviously, the more time that you spend working at night time on a weekends, the less time you have face-to-face with your what we call our core specialty. So if I work on a night shift, yes, I'll see respiratory patients, but I won't be working alongside a respiratory consultant. So therefore, you don't get that kind of education and feedback that you'd normally get. So junior doctors have been amazing that they've been so flexible to change their rotas so quickly. I do want to emphasize it's not just junior doctors who have changed their rotas. As we all know, physios, nurses, respiratory physiologists, from my point of view, physios, everybody has had their rotas kind of upended. And a lot of them have been redeployed into new areas that they're not as experienced or competent as well. But junior doctors have done this several times now, often without much notice. And as I said, one of the interesting about junior doctors is we are rotational. We work generally either in a 6-month or 1 year post in hospitals. And so we haven't got that organizational memory of how our organization or system works. So if you've just been redeployed to a new hospital and then a week later redeployed into a new department in that hospital, that's very jarring because you haven't yet got your feet under the table, never mind be moved somewhere else. But junior doctors have really stepped forward. There's an amazing body of evidence now, and some of it published, like in the Future Hospital Journal a few weeks ago, about junior doctors stepping forward and rewriting rotas themselves, working with rota coordinators, business managers, clinical directors because they see the pressures at 4 o'clock in the morning without being rude to consultants. They're not generally there at 4 o'clock in the morning. So the junior doctors definitely are aware of where the upcoming demand and pressures are, and have volunteered to kind of do things like rewriting rotas, knowing that they're going to have to make the working lives harder for themselves and their peers, but they've agreed to do it because they realise what the demand is. Yeah. The next step that we have to do is to support the systems, including the junior doctors, of trying to get back to a new normal. And my worry for some of the systems that I know quite well is that their new normal is a lot different to how it was a year ago, i.e. their on-call rota duties are a lot heavier than they ever used to be. And that just means that your percentage of time that you're able to do your education is dropping. And unfortunately, that might mean that new normal just isn't as appropriate as it used to be. So I think we...
Yeah, sorry. So what do you mean by your on-calls heavier? Is that because of...
So when I say heavier, it could be the demand that you have, i.e. it's heavier seeing more patients, but mainly it's the frequency. Okay. So obviously, if you're more on call more frequently, you're not going to be in your base specialty as often. And I have really good examples where, for example, pre-COVID, the junior doctors were on a 1 in 6 weekend rota, but now they're on a 1 in 3 weekend rota, and there's no plans to change it back, because this new normal, the hospital appreciates it, because more doctors on the floor on a weekend is better for everybody. Yeah. And I'm not saying that's not the way that we should be heading to, but actually the 1 in 6 offered a lot more educational opportunities, and now you might be missing half of those opportunities that you had before. So it's just a time that I think, as we're coming out of this second, third or fourth wave, depending which part of the country you're living, we just need to reflect that A, everyone needs a little bit of a rest, which is understandable. That definitely isn't just junior doctors. But B, when we go back to what we're now assuming our business as usual is, that we don't take all of the potential improvements of COVID as the norm. We have to say, are these things sustainable? And I suspect, unfortunately, some of them aren't. Just as a really, I'm not going to give you the hospital, but as a specific example, that there is a bunch of my peers in one hospital in the Midlands who will be on a surge rota, i.e. a more intense rota, for about 9 months of this 12-month period, because their COVID rota, as it's described, is being planned at the moment to run up till August. And that just, you can imagine what the impact on people's well-being and rest and all those things is massive.
It's really interesting. Obviously, from an ECIST point of view, we need to be thinking about how we support the systems that we work in, because obviously we do talk about the need for 7-day working, but it's we need to recognise the pressures that the hospitals are under, and the impact that it has to do that, given the workforce challenges there. So you talked a little bit about some of the positives that have come out of the pandemic. How do you see the future really for what sort of roles do you think might come out of this for some of the junior doctors? Because I think the well-being of them is essential, isn't it? I mean, it's crucial for them moving forward. A lot of them will perhaps have young families that and making quite difficult life decisions really, and career changes.
Yeah. So I think one of the things it's highlighted is that role of junior doctor leadership within systems. And I think the really good systems have known that for a while, and the really good systems have invested in roles such as the Royal College of Physicians chief registrars, and they don't have to be medical doctors, even though it's run by the Royal College of Physicians. They could be surgical doctors and anaesthetic doctors for primary care, but that means that someone is paid to be in each organisation, and these are generally acute providers, to be that link between junior doctors and the senior management team. And so really good organisations have had those working for a few years, and I did a similar role 4 or 5 years ago in a trust in the East Midlands. And the benefit of those roles is it becomes the precedent, it becomes the norm that junior doctors are involved in the senior decision making. And I hope that for the organisations that have chief registrars, they really saw the value in COVID, because it helps with communications, junior doctors, because we have our own networks, WhatsApp, Facebook, all those kind of things. But we're also able to tailor those communications specifically to junior doctors, but we're also able to express the the demands and the frustrations of junior doctors eloquently as well. So those organisations that already have chief registrars and other senior leadership, I hope they've really found the benefit of them. The organisations that haven't, I hope they see the benefit of potentially taking on those roles. There were some great examples. I'm thinking of, say, Stoke Hospital. They have a weekly meeting between their directors of medical education and a panel of junior doctors. Right. And those junior doctors are able to feedback on a week by week basis any changes to the pathway, any risks that they see to patients, any improvements they're suggesting. They're able to feedback the demand and the capacity kind of challenges that they're sensing on the shop floor. So that communication back and forth between sometimes exec level staff and the junior doctors, I think is hopefully a precedent we can just carry on with. They really good organisations in my mind, from a junior doctor point of view. There are certain meetings that we should just be a precedent that junior doctors are engaged in them. And I think especially any meetings that involve hospital out of hours type programs, you've got to think that only 40 hours of the average week are in hours. So that's only about it's less than a quarter of all the hours in the week basically are in hours. And all of the out-of-hour medical service is generally junior doctor led. Obviously, there's a lot of consultant supervision for juniors, but it's junior doctor led. So any meetings that involve out of hours, which is when an awful lot of our discharge processes, especially for ECIST, fall down, those kind of conversations we should be having junior doctors engaged in. So whenever I go to sites with ECIST, I always inquire about how many staff they have working on a Saturday afternoon, what seniority of those staff are, how they're able to do discharge summaries and all the things that end up being a single point of failure that only junior doctors can do. And if they have, the important thing I think, not just to support junior doctors, to support systems and flow, is if they look to any of our kind of allied health professionals, if they've got pharmacists doing discharge summaries, if they've got advanced care practitioners doing discharge summaries and all the other roles that historically we assumed are only able to be done by junior doctors.
Yeah, I think it's crucial that we see the individual specialties of the MDT as a team, and not just it's your role. It's, from a prescribing point of view, you've got nurse prescribers, you've got physios, you've got other allied health professionals that can support with that. But we do seem to be stuck sometimes in that it's a doctor that needs to do that.
And I'm sure from a nursing point of view, you will have the same frustrations that some roles that only it seems to be a nurse that can do. And and I think there's been some really good examples. There was the project, I don't know if you've heard of, Claire, called the Spaces project in Leicester. Okay. About trying to reduce the idea of this was trying to reduce exposure to patients and staff during the COVID pandemic, so that if you the idea behind it is if you saw a patient for whatever reason during the day, you thought holistically about what that patient needed at that time. So you could be a consultant going in to see the patient. But when you went in there, you would take in food and drink if it was the time of the day for that. You would maybe do the blood pressure and oxygen saturation so that the nurse or the HCA didn't have to go in later into the day. And I think those type of projects are great because it blurs those boundaries between what is traditionally a nurse, a HCA, a doctor, a physio's roles, because some of them, by definition, definitely a nurse is better and more safer at delivering medication than I as a doctor would be, because you guys do it and you're trained to do it properly. But on occasion, me taking that medication to the patient, if I'm going to see the patient, is the right thing to do. But so anything that kind of encourages that team to work as a team is, rather than as individuals, I think is fantastic.
Yeah, I think we'll definitely see some of the, obviously the beneficial changes program. We're going to see some great stuff that's come out of the pandemic. But you do, I think you mentioned earlier on as well, we just need to be careful that we don't just carry on with something because it's worked during that pandemic without reviewing it. Obviously, we would always say do a PDSA. Let's just check that it's still the right thing to do. Otherwise, it becomes we've always done it that way, doesn't it? So. So it's been really good to chat today, Dan, and I've got a bit of a vested interest in it because I've got a teenager who's just about to start her A-levels who wants to go into medicine. So it's been quite interesting to sort of listen to and start having those conversations with her about how different it will be if she's successful when she goes forward. So thanks very much, Dan. I'm sure there's loads more that we could talk about. I'd love to catch up again, because I'm sure we've got a big list of things that we could chat about. And we'll see you soon. Thanks very much.
Thank you, Claire. And if your daughter or anybody else who's watching these videos wants a bit of a chat with myself about kind of future career plans in medicine or anything, I'm very happy to have those conversations.
Oh, thanks, Dan. And I've got your Twitter handle, so you'll be getting mithered to death. Cheers, Dan. See you later.
Thanks, Claire. Bye-bye.
Bye.